Good afternoon, everyone, and welcome to the Independent Sage briefing. Now, since the start of the COVID-19 pandemic, there have been several groups that have been more vulnerable to the virus for various reasons, but this holds especially true for immunocompromised people who've continued to have their lives disrupted as the rest of us have returned to some sort of state of normality with work and with social life. Having had to be careful to avoid infections even before the pandemic, things have become worse for them with the need to shield themselves from COVID. And today we're going to talk about this community, sometimes known as the forgotten 500,000. Before we look at their concerns and to see what measures can be put in place to alleviate their troubles, I'm going to invite Professor Christina Pagel to present the latest numbers and trends. Over to you, Christina.
Thank you. Right, just sharing my screen. Okay, so the numbers today. So I'm going to cover hospitalizations and deaths. You'll notice that prevalence is no longer number one because there is no more ONS infection survey. Then I'm going to give a brief update on vaccines and the latest long COVID report, which again might be the last one we get. And then just a reminder that there are things that are going away, but COVID is not one of them. And then just a couple of graphs about vulnerable people to kind of motivate today's session at the end. So in terms of hospitals and deaths, this is the number of people in hospital with COVID per million people for the UK nations up to the end of March. So you can see that Wales is coming down, Scotland is still going up, and it's pretty flat in Northern Ireland and England. In terms of new admissions in England, you can see that we are now coming down. There was a 9% drop over the last week. So that is good news. A slightly different pattern to previously. You can see it went up less quickly than before, but stayed quite high for quite a long time. And I don't know what's coming because I just don't know. There's just so little data out there. I don't know if it's going to keep falling. I don't know if it's going to go up again or when. So this is what it is. The one bit of good news is that one of the things that came out of last week's ONS infection survey, which went up to the 11th of March, data 11th of March, is that we had really, really high rates of COVID in the over 70s. Almost 1 in 20 of the over 70s were infected. And this was reflected in really high admissions. This is over 65s. Now that is now coming down. So that is good news. But again, this kind of data is going. And the other kind of sad thing about hospital data is that there is now a change. And basically the NHS is taking stock of who it tests and when it tests in hospitals. We already had reduced testing as of last summer. Now this is likely to be reduced further. So it's not really that clear who's going to be tested in hospital. I imagine if you're in hospital, because of COVID type symptoms, you will get tested for COVID, but otherwise it's not clear who will get it. And again, this is from the NHS earlier in March. And they say they expect that there'll be a reduced requirement for PCR testing in both patients and staff. And just also to note, that the proportion of admissions that are in hospital transmission is about 30%. So there is still a problem with people getting infected in hospital. This isn't going to help. It also means that the hospital data is going to become less and less comparable to previous waves and less reliable and less of an indicator of what community prevalence is. So we're kind of losing at the same time, two of our best forms of knowledge about how much COVID there is around. In terms of deaths, we do have the ONS death data. This is it up to 17th of March, and basically corresponding to recent increases in prevalence, deaths are going up. They probably will go up for a few more weeks yet, hopefully not that much, but that's where we are. So on vaccines, we've been showing this kind of vaccine recency. There's basically no one getting vaccinated at the moment, so there's no new kind of vaccine data to show. But we are now in a situation where pretty much everybody is at least 3 more than 3 months out of their previous dose, and 80% of people are more than 6 months out of their previous dose. And in fact, it's probably about 40% of the population are now over a year since their last dose. So the vaccines will still be protecting against severe outcomes, but probably not really against infection. If we just look at the over 80s, you can see that even for them, about 2/3 are now more than 6 months out of their previous dose, and about 1/3 of them 3 to 6 months, and hardly anyone within 3 months. So, the spring booster program will be starting next month for the over 75s and other vulnerable people. So I think that is quite timely, because we do know that protection wanes more quickly in older people. There's also the long COVID, the ONS Infection Survey published its long COVID report this week. I assume it's the last one. It's one of the only population level long COVID surveys in the world. It's been incredibly useful. But I assume it's going with the ONS Infection Survey, but they haven't really said. So where are we? This is the number of people in the UK reporting symptoms for more than 12 weeks, so 3 months. It's at 1.7 million people. It's been kind of fluctuating between 1.7 million and 1.9 million for the last, 6-7 months. So it's not going up massively, but it's also not coming down massively. So basically, the number of people who are recovering from long COVID, and not most people do recover eventually, are kind of matched by the number of people developing new long COVID. It's not really a great situation. That's still a significant proportion of the UK population. And remember, it's concentrated in kind of working age adults. Of people who report long-lasting symptoms, about a fifth say it doesn't affect them at all, and about a fifth say it affects their everyday activities a lot, and 60% say a bit. So, pretty much 80% of people are saying it does affect them in their daily life. So again, it's not inconsequential. Just to kind of reflect on where we are as the data kind of disappears, is COVID is not going away. This is the ONS Infection Survey for England up until the last day. So this is the arrival of Omicron. You can just see we've had these repeated waves of infection. And this is kind of the gold standard for knowing how much COVID we've had around, and now it's gone. So, but COVID hasn't. And in fact, the last information that we had was that it was going up. I also just wanted to highlight, so the ONS did a pilot test over this winter, so from October to February, not just testing for COVID, but also testing for flu and RSV, so 2 other respiratory viruses, in a subsample, just to kind of see if they could do that and what it showed. And they published the results this week. And it's been really interesting. And I think it's a really, really good use of the kind of infrastructure that we had in the ONS Infection Survey. So this is what it showed for this winter. This is a chart by Paul Mainwood using the ONS data. So this red line is COVID prevalence, the green line is RSV prevalence, and the blue line is flu prevalence. And you can see all of them had a big winter peak. COVID has been higher outside of the winter season by quite some margin, and there's no reason to think that that isn't going to continue. But really, the 3 of these together, all spiking in December last year, really has kind of contributed significantly to the NHS winter disaster. And I'm not calling it a winter crisis, because it isn't. It was a disaster and significant kind of collapse of NHS emergency services and access to emergency care. Now, what worries me is there's absolutely no reason to think this isn't going to happen again next year, right? We had an NHS that had an annual winter crisis with just RSV and flu. We've added a 3rd significant disease to that population, to our population. And what are we doing to prepare for next winter? I have no idea, except that we know that we're massively under-resourced in terms of staff and funding for the NHS. And we also have this added pressure of COVID outside of the winter season, as we can see here, of COVID hospital admissions versus flu admissions over the last year. And this is continuing. So we're kind of in a situation where we know it's going to continue causing problems, but we're now kind of losing our measurement of it. And I think had we kept the ONS infection survey and monitored for other infectious diseases as well, we could really have understood how do these things spread, in which age groups, when, and so on. So just to finish on some information about clinically extremely vulnerable people. Now, the kind of data that's out there isn't specifically for the clinically extremely vulnerable. It's kind of done by, well, different surveys use different measures, but kind of people who talk about being limited a lot in their daily life, or people who report being in poor health. So the first thing is just looking at vaccine coverage by disability status in terms of how limited by self-report for adults in England. This is as at 2nd of March this year. And I think what's worrying here is that you can see that the highest percentage of people who are unvaccinated is in people who report being limited a lot. So 12% unvaccinated versus 5% unvaccinated in people who report not being limited at all. And across all categories, about half people have had a 4th or a 5th dose. If we look at it by self-reported health status, there's less of a difference, but you're still seeing that 12% of people who report being in very bad health have not been vaccinated at all, which I think is quite worrying. You have a much lower percentage with a 4th or 5th dose of very good health, but that makes sense. A lot of these people will be younger adults who are not eligible for a 4th or a 5th dose. Another place where we can see the impact of COVID on people who are more vulnerable is in long COVID, and ONS has published self-reported long COVID by health status. And this is just showing you, so this is people who say they're not limited at all by health conditions, so kind of healthy people and people who report long COVID. A lot of them are reporting no impact of long COVID on their life, and about half of them some impact, and very few are saying it impacts them a lot. If we now look at people who say they're somewhat limited by other health conditions, you can see that actually very few of them say they're not limited at all by long COVID. It's a much more severe problem. And then if we look at people who say they're limited a lot by other health conditions, so our more vulnerable people, you can see that actually it's a much higher burden of significant impacts of long COVID on top of the conditions they're already living with. So long COVID is having a very disproportionate impact on people with other vulnerabilities. And finally, just looking at deaths. Now, this is COVID deaths by disability status. Again, it's an ONS report. This is actually came out a year ago. So this is going from deaths from January to March 2022. And this is looking at it adjusted by age, because there's people with vulnerabilities are not equally distributed across ages. And what you can see here, so this is men, this is women. You can see in general, men had a higher death rate from COVID, which we knew already. Blue is people who are reported as being not disabled at all. Red is people who are most disabled. And you can see there's a much higher rate of age-adjusted death, 3 times higher for men who are most disabled compared to men who aren't, and 4 times higher for women who are most disabled compared to women who are not. Now, you can then adjust, and ONS did this, they adjusted for all kinds of other factors. You know, are you living in a residential facility where you have higher exposure, the demographics, vaccine status, and so on. And once you've adjusted for all those other socioeconomic factors, it's the bell, this keeps going. And so even then, you still have a much higher risk of death if you're most disabled compared to not disabled. It's between 30 to 60% higher once you've adjusted for it. So there is a significant increased risk of death for the clinically extremely vulnerable. So just to summarize, that from hospital data, it looks as if current cases are coming down, and which is good. But I just don't know where it's going or how long it's going to last or anything. I don't have a crystal ball at all at the moment. Almost everyone now is at least 6 months out from a vaccine dose. Many are over a year out. Spring boosters start soon for the 75s and over and other at-risk groups. The over 50s will probably be getting an autumn booster. Everyone else not going to get one ever, as far as I can see. Long COVID numbers are falling, but really slowly, and they stay really high. And 80% of people with long COVID are reporting some impact on their daily life. So again, it is causing problems for people. And clinically extremely vulnerable people have been hardest hit by the pandemic so far, and they also are the least protected now. And with that, I will hand over to Helen.
Thank you very much for that fantastic presentation, Christina, although it was really quite depressing, particularly about the lack of information that's on the horizon. Difficult to know how we're going to know what to say. We're going to move on to our main presentation now. We're going to discuss issues that concern immunocompromised people. Dr. Lennard and Dr. Stephen Griffin are going to lead this discussion, and I will ask them to introduce the session and our wonderful guests. Over to you, Lennard.
Thanks, Helen. Appreciate it. Thank you, Christina. I mean, it's always interesting to see the data because the data stands for itself. But the session today is centered around protection. I think it's really important because data streams are being turned off. You can see that. COVID's not going away. And actually, as Christina said, we should be thinking about protecting our healthcare system now for this winter. I think there are many clear solutions here, many easy wins. And we're going to try and talk about some of them for one particular group. I'm Lennard. You've probably not heard from me much before. I'm the newest member of Indy Sage. I'm an associate professor at Oxford. And I guess the question we're going to answer today is, how do we protect those at risk, particularly the immunocompromised? These are people with weakened immune system. They can be young or old, and they're not really that well protected during the pandemic, and they haven't really responded very well to the first generation vaccines. Today, you're going to get a really fascinating insight. It's about the pandemic forgotten people. To set the scene, think about how you felt in 2020. Think about all the sacrifices you made and the difficulties that we all endured together. And then think about why we did it. I think we did it for a few reasons: to protect the vulnerable, to help those in need, and to save lives. And the question we're going to answer in the next few 20 minutes or so is, how are we doing on these fronts? And then the bigger question is, what would it feel like if you had to continue to make those sacrifices into the 4th year of the pandemic? So with that in mind, let's bring in our two guests. The first is Mark Oakley. He's immunocompromised. He's going to tell us about his experience, his lived cliff edge experience, and then we'll follow with the science. So Mark, tell us a bit about yourself and tell us what you're going through.
Good afternoon. I'm Mark Oakley. I'm 53 years old. Prior to the pandemic hitting, I ran my own landscaping company. And before the pandemic, I lived as much as a normal life as my condition would allow. I was diagnosed when I was 41 years old with sarcoidosis. It affects most parts of my body, but it's mainly affects my lungs. It's a rare disease. About 4,500 people a year get diagnosed with it, and I have to take immune suppressing drugs to control it and allow me to control the symptoms and live somewhat of a normal life. But although my condition is rare, there's about 500,000 people with other illnesses and diseases that are in exactly the same position as me.
Mark, what's happened when the pandemic hit? What have you had to do?
When the pandemic hit, it was kind of like a sledgehammer, really. It was very scary at the time. I think we can all remember seeing the pictures of patients in Italy in the hospitals. And it was just that stark realization that it was definitely coming our way, whether we liked it or not. Basically, the front door got closed. And like everybody else, I guess, in this position, we kind of hunkered down, and it became clear it was just going to be a playing for time, really, until, you know, vaccines or some treatments came along to offer us a way out. And at first it was scary, but everybody was in the same boat. It didn't matter really what your condition is, whether you were fit or healthy. Everybody was doing the same thing. And I think to some extent, some people almost enjoyed it. It was a chance to get away from everything, from work, just be with the family and spend time together. But as things went on, it got harder and harder for those people that are in this position. especially as things started to open up at the end of each wave. You were faced with more and more difficult choices of how to protect yourself.
Mark, do you want to talk about some of the difficult choices that you're faced with at the moment?
Yeah, I have a family with 3 children. My eldest child, she's 31, so she lives separate from us. I spent nearly just under 1,000 days of shielding, and during that time I couldn't cuddle her, could only speak to her at a distance. As things changed and the children went to school, my second eldest, who's 17, and my 12-year-old, you were faced every day really with decisions of how to try and give them a normal life but protect you. And they would go back to school, and they would have to take protections, and they would be living with the fear of bringing back in the virus into the house and making dad ill or possibly worse. It meant restrictions on their life that you didn't really want to do, and it's a real mental toll at times to protect myself or to give them the chance of a more normal life. I would live separate from the family, summer house in the garden, and I think probably during all that time I did it, I spent about 7 months living separate from the family. They caught COVID on two occasions, and it was absolutely terrifying. Couldn't go in the house, couldn't go near your children, when your instinct as a parent, when your children or your wife is ill, is to try and care for them, and all you can do is wave at them through a window. It's been a real hard, difficult road. I lost my business because of it, because it had to shut down. And you lose contact with people because they go back to a normal life, and life carries on, and you do just become a forgotten person. You might get the odd telephone call, the odd Zoom meeting, or someone just pops around occasionally, have a cup of tea outside, but it's hellishly difficult, and it's not a way to live a normal life when, to some extent, you're capable of doing it and contributing back to society, and you just can't do it.
Pretty hard, Mark, I think. And the thing is, it's the drugs that we're giving you to keep you well, which has caused you to have a weakened immune system. And we know that people with a weak immune system catch bugs very easily, and they get bad infections. And the fact that there's so much COVID out there means that you're living like this. I want to bring it back to one of your key points here. We were in the same boat. Are you still in the same boat with the rest of the population?
No. I mean, I've been lucky enough back into November. I had the drug Evusheld, which has given me a significant level of protection compared to what I had before. I was fortunate to be able to raid my own savings to be able to afford it, but so many are not in that position to get that drug that's been denied to them. It's not a magic bullet, and I know it hasn't made me invulnerable. I still have to take a lot of precautions, be careful. I pick and choose where I go. If I go on things like, if I go to London to see my my consultant, I have to pick a train that's at a quiet time, be masked up, just be really cautious of things. But I've now got the option to make that decision of what I do. I've got that freedom that I didn't have before, and so many people still haven't got, and it's just not fair. That people are in this position. It's a difficult way to live your life, constantly looking over your shoulder and planning what you do like this, rather than just having the freedom of being able to walk out that door without care in the world.
It's quite a simple ask, isn't it, to hug your daughter, not have to live in the shed, and just return to normal life. I mean, I think it comes back to the things that we thought we were going to be doing here: protecting the vulnerable, helping those in need, and saving lives. Mark, I think you mentioned that you had to pay for your own protection. Do you mind explaining a bit more about that? Because I thought most people got their protection for free.
yeah, I think most people did until we got into this situation. And it's quite apparent that things aren't quite what they used to be, isn't it? There is a drug called Evusheld, which I'm part of a campaign to try and get free to everybody that needs it, but we're still fighting that fight. Part of that campaign, AstraZeneca, the company that makes it, have made it available, but it's only privately, and so people have got to pay for it.
And Mark, I'm keen to steer the conversation away from single drug names, but if a new drug came along, the second generation vaccines, how confident do you feel that you'll get it straight away?
Based on everything that's gone so far, I think confidence is something that's severely lacking. I think anybody in this situation would willingly would give any drug a chance if it's if it's proven to work to some degree. But people that are going into their 4th year now need it urgently, and it seems to be that we're running through treacle to get these drugs. It just seems that everybody here is just really is forgotten.
The forgotten bit's interesting, Mark, isn't it? Because you can't go out, it's hard to see a doctor, you can't meet your MP, so how do you make your voice when you're all stuck in your little rooms by yourself? What can be done?
It is difficult because you are forgotten, because you're not seen. It's not like people can sort of walk down carrying placards and doing a big protest, and so it really is a slow process of keep writing to your MPs, nagging them, and just being active and not giving up. But it's difficult. And as we've seen in the last week, with more and more of the protections and mitigations being removed, it's becoming harder and harder to get that voice heard.
No, that's really helpful. I think, and that's what Independent Sage is for. I think we've said that having this much virus out there, it's not helpful. It causes long COVID. It spreads amongst schools. Vulnerable people are affected, and it does affect people. And you're saying it's about 500,000 to 1 million people. So this is really, really important. I'm glad there's actually people listening to this. And thank you, Mark, for testing me. Mark, if you were to make a final point on what you want to say, was there anything you want to try and sum up, key messages, if you can?
Yeah, I think people in my position sit and watch Indie Sage every week, and it's absolutely invaluable, the information that it gives. But we sit here every week and we watch more and more people becoming ill and people having to live a restricted life, and we watch more and more people dying, and it's frightening. And we're needlessly ignored because they pretend that everything's okay. And we've seen it this week as they dismantle more and more protections around us and just tell us it's okay. And it's not. It's not okay at all. It's not okay for the vulnerable people to be treated like that. And it's not okay to leave people living like this. We're forsaking their protection. It's difficult for people to go to hospital. None of this is okay. It's far from okay. And it's sickeningly wrong for the over 1.2 million people that are in this position. And that's too many people to tell that it's okay and just forget about it and move on.
Thank you, Mark, for making those points so poignantly and so heartfelt, and for really speaking clearly about your lived experience. It really is something that as Lennard said, we've tried to get this message across endlessly, and it seems to fall on deaf ears still, unfortunately. But now, thank you, Mark. We'll hopefully come back to you later with questions and things later. But now we're going to hear from someone who we've had on Indie Sage before. It's great to welcome her back. It's Professor Alex Richter, and she's going to tell us more about the sort of state of therapy and provision for people that are in vulnerable positions. Alex is a professor of immunology at the University of Birmingham. She's a wonderful advocate for vulnerable people and for science and understanding this area. She's also an incredible athlete and an Iron Woman, no less. So on that note, I'll hand over to Alex, who I think is going to show us a few slides about what the situation is clinically at the moment. Over to you, Alex.
Thank you, Stephen. I actually find it very, very difficult to follow. It's an incredibly powerful testimony from Mark. And Mark is not alone in this. This is the stories that I hear every Tuesday afternoon in clinic. And I think that's what, should drive us to keep going, to really understanding this clinically vulnerable cohort. And a discussion I've had with Mark and with the other vulnerable groups is that actually people have always been vulnerable to infections, and they've been disproportionately affected, for example, by flu and other infections. And the winter pressures or the winter disasters, Christina, that we hear every year aren't because of the young being admitted to hospital who are fit and well. It is because of the clinically vulnerable. And actually, I think as a society, we must do better, and we can do better, but by working together. So I want to I can't give you much that's positive, but what I would like to do is be honest and say where we are, and just ensure that we have as much information as possible. I think communication over the next year is going to be absolutely essential. And, forums like this are going to be increasingly important. So what is the impact of COVID on the clinically vulnerable? Well, if we think back to spring 2020, we were at the point when there were, up to 8,000 deaths a week. I mean, shocking numbers. Massive increased risk of bad outcome, not just death, but long-term disability, having been on ventilators and been unwell at the beginning of the pandemic. And then through the waves, undoubtedly, things have got better. And if you look at the little graph in the middle of deaths over the pandemic, after vaccination, things undoubtedly got better. But what also happened was that we got more treatments available. So outcomes have improved for everybody in the pandemic. And it's a combination of approaches. It's the vaccines. It's the fact that so many of us have had COVID already. And so we've had some immunity from having had the infection. But also when people become unwell, we've got early treatments and treatments for those that we know how to treat you better now if you come into hospital. But I just wanted to point out that, the data that I had, and obviously it's moved on a little bit, we're somewhere between 500 and 700 deaths still every single week in the UK from a single virus, okay? COVID's not over. And COVID is not a cold. People don't die from having a cold. So whilst things have got much better, there remains an increased risk compared to the general population. And a number of studies have shown this. A big hospitalization study called ISRIC showed that the immune vulnerable and the clinically vulnerable were much more at risk. I've shown this in a group of immune deficiency patients through a study called COVAD. So we've got a lot of evidence that there are still patients who are clinically vulnerable attending hospital. This is despite vaccination, 5 doses. Some have had 6 doses of vaccines. And this is despite getting antivirals through the COVID medicines delivery units if they test positive, and despite having treatments available when they're admitted to hospital. There is still an increased risk for these patients. I was just looking to update myself on the guidance from government on COVID-19 for those whose immune systems mean that they are at higher risk. And there was a stark comment that resonated with me that I felt very uncomfortable with. Most people who were part of the CEV patient cohort are no longer at substantially greater risk than the general population. So there's almost a misunderstanding about the vulnerability of this patient group, you know, through policy. So as Mark alluded to, there's been a number of decisions that the National Institute of Health and Care Excellence have been involved in. There was a recent nice policy guidance around COVID treatments, and then there was a separate policy around what we call pre-exposure prophylaxis. So if you imagine that you get immunity from vaccination, for many of my patients and the vulnerable, you can't respond to a vaccine. So what pre-exposure prophylaxis does is it gives you antibodies in a form of passive immunity. So it's like donated immunity. And that's what Mark had in the form of a medicine called Evusheld. Now that wasn't rolled out or recommended by NICE as being cost effective for the UK. And in fact, no pre-exposure prophylaxis treatments were recommended. So the focus was on early treatment. So if you become unwell with COVID, and you can then access treatment through the COVID medicine delivery units, you can have now either Paxlovid, which is an oral tablet antiviral, and this is just for adults who don't need oxygen, so have a milder form of the disease, but who we know are in this vulnerable group and who have a risk of progression to COVID-19. Now, there had to be a fight for this, but sotrovimab is another form of antibody donation therapy, an antibody infusion. And we can give sotrovimab where Paxlovid is contraindicated. So the problem with Paxlovid is that it has a number of drug interactions and is actually not recommended in people with a number of underlying health conditions. So given that most of our clinically vulnerable patients are on a lot of medicines and have a number of organ problems, it becomes very difficult. So we're going to, but we do have this option now of sotrovimab. And there is some evidence coming out that sotrovimab is reasonably good, at least in the laboratory, against these newer strains. And then unfortunately, if people get to hospital, we do have one drug available, apart from dexamethasone, which would be standard, and oxygen, and that is tocilizumab, which is an anti-inflammatory infusion. Now, we have complete uncertainty and no data for what do we do if one of our clinically vulnerable patients can't clear the virus. So I was looking after a patient who had now been positive for 15 months. And we didn't know how to clear the virus in him. And our options for trying different things are very limited, and we don't have any treatment guidance in hospital at the moment. And my pediatric colleagues are very frustrated because all of these drugs are for adults, or at least the over 12s. So moving on to boosters, the government's now announced spring boosters, and they've said that this will be that with some of the vaccines we've heard of before, Pfizer or Moderna, but also a Sanofi vaccine, which is slightly different because it's got this little enhancer in it called an adjuvant. And I'm really interested to see how that performs in the clinically vulnerable. Why are we doing this? Well, there's good evidence from now across the pandemic that waning from vaccination occurs within 4 to 6 months, and that's if you've made an immune response. And many of my patients have made a lower response, and so they wane even faster. But it's much more limited, this spring booster. So it's only going to be for the over 75s, and that'll be from the 17th of April. For residents in a care home for older adults, and that's going to be slightly earlier from the 3rd of April. And then for certain risk groups, for the clinically vulnerable, and those are on certain medications. How will people be able to access this? Well, they'll be invited for a booster, but actually these individuals can also book online using the NHS app or their nearest walk-in centre if they look on the NHS website. But it'll be important to encourage anyone that hasn't had this vaccine over the next 2-3 months to get involved. What will happen next, we don't know. And there's evidence that different types of vaccines might be coming, and hopefully those will at least be tested in the clinically vulnerable so that we know how the clinically vulnerable will be protected from these vaccines going forward. So the overall strategy for COVID really seems to be we're going back to business as normal. And that is seen by the decentralization of all the infrastructure that was put in place for COVID. So for surveillance, the COVID-19 dashboard and the ONS, as Christina has illustrated, the antivirals and therapeutics task force, which has been looking and signposting medicines and adoption of medicines, will now be left to NICE. The COVID medicine delivery units are being dismantled, and that's now going to be delivered by the NHS through integrated care boards in England. Less certain than devolved nations, but actually how that's going to be delivered, we don't know. And one thing we're really keen on advocating for is that actually there is a really clear message that whoever this is devolved to knows what they're doing with the clinically vulnerable. You know, we've got RED of regular screening, but we've had reassurance the lateral flows will remain available and be orderable for those who are eligible for treatment for these treatment groups. Research has also been stood down. All that money for research and the National Core Studies Programme is being stood down to the standard research funding body. So we're in competition, as we were with all other medical conditions. And I think communication is also being stood down. So the Enhanced Protection Programme is being stood down. And this is going to be divulged much more to the UK HSA and NHS. The one thing that has been funded, I'm very proud to say, is a study called Stravinsky, which is stratification of clinically vulnerable people for COVID-19 risk using antibody testing. Now, this is a big partnership in the UK, and really, cutting to the chase of it, our ambition is to help every patient know what their individual risk is from infection. So whilst we will be looking at what the importance is of the value of an antibody test for an individual, which they'll get that result, we will also look much more widely at the other things that classify their risk. And hopefully this will allow people to really consider their own risk and decide what things are worth doing for them and what measures they want to put in place to protect them. And it'll help the clinicians that are looking after them, help guide them. So this will be for 3,000 clinically vulnerable patients across the UK. Please bear with us whilst we're getting up and running. But if you want to look on our website, on the British Society of Immunology website, all our keeping in touch will be done through there and through Twitter. So there are other studies going on looking at some of these other treatments, Evershell that we've talked about, the next generation of some of these treatments. So do keep involved if you are in the clinically vulnerable cohort, and we will try to keep signposting these studies to you. But we're absolutely sure this pandemic will continue to evolve. But not just this virus, but lots of other viruses, as we've seen that graph of the not just twindemic, but tridemic this winter. And we will need to know how to continue to support the clinically vulnerable, not just for COVID, but for all these infections. So, you know, the NHS gives guidance on keeping yourself safe. I don't believe in this statement. I don't think anyone is safe. I could walk out and walk under a bus tomorrow. For me, this is about keeping yourself safer. And that has got to be from an informed viewpoint. You've got to know what your risks are. And there are things that you can do to manage that risk. Thank you for listening.
Thank you, Alex, so much. That was so clear and so informative, slightly depressing in terms of the limitations of the therapeutics that are now available compared to what we had when they first started suggesting living with COVID. Can I just ask you and Mark extremely quickly, because we have to go to public questions, this idea of scaling everything down and putting everything back into the mainstream, do we agree that this is going to work, or do we foresee problems?
I think from having sat and listened on the EPP panel at the beginning of the week, there's still a lot of things that just haven't been planned properly yet. There's things that were raised back in November by us and other charities. Simple things like out of hours when it goes back to GPs and having to deal with antivirals, and they still haven't got plans put in place, it would seem. So I don't have a lot of confidence as a patient sitting on this side of it.
Well, that's very important to hear, Mark. Thank you. Right. Well, I think we need to now head back over to Helen, who's going to chair our public questions. Thank you so much, both of you, for giving your time and for putting the case around this really massive problem that's still ongoing so eloquently and heartfelt. And I'll hand over to you, Helen.
Thank you very much, Mark and Alex. That was what we try and do on IndieSage, which is the stories, that things that matter to patients, but also the science that surrounds it. So with brilliant presentations. Thank you both. And thank you to Stephen Lennard for those introductions. We're going to move to our questions and answers now. And our first question is from Vicky, who I think is here. Vicky, would you like to turn your camera on and microphone and ask your question? Are you there, Vicky? Oh, we may have lost her, in which case we'll move on and hope that she might come back to us. Okay, so
she's here, Helen.
Oh, Vicky, you're there. Lovely. Would you like to ask your question? We can't hear you, Vicky. Can you turn your microphone on? Okay, fine. I'm really sorry that we can't hear Vicky. I'm going to read her question out. Okay. So Vicky's question is about the WHO, the World Health Organization's latent vaccine guidance. And it says,
yes, I am. Hi.
Oh, lovely. Yes, we can now. Vicky, go ahead.
The button wasn't working. Sorry. My question is, I've read on the 28th of this month that the World Health Organization updated their COVID vaccine guidance so that fewer people will be given the vaccine. And basically, my question is thinking about the vulnerable people in particular, but everyone, of course, because the more people who are infected, the more that everyone is at risk, including them. What do the panel think will be the effect on reducing the access to COVID-19 vaccines?
Okay, who would like to respond to that question? Sheena, go ahead.
I can say a little bit about this. I think these decisions that are being made, I think partly they're looking at resources and the costs of vaccinating populations. We still got quite a lot of the world that never actually got the first tranche of vaccines as well. I don't think they're necessarily saying these statements. They might be being misconstrued in some quarters in social media, for example, that it means that there's an assumption that the vaccines are not as important in certain groups of people. I really don't think that's the case. I think it is worrying because we are getting further and further out from our vaccination coverage. I would, however, like to see a better understanding of what long-term protection looks like, what it means immunologically, but also a move towards trying to develop more robust vaccinations. I feel that we need a vaccine strategy that's a little bit more long-lasting and more equitable, so that we aren't getting these huge gaps in coverage from lower income countries, as well as gaps in coverage within countries. And I also think it's really important that we're very clear about which vulnerable categories are going to get prioritized for those vaccines, because at the moment, the kind of advice I'm seeing isn't as clear as it should be. And I would also include pregnant people in that, because pregnant mothers are more susceptible to COVID, and we know that the maternal protection that they provide the baby as a consequence of being vaccinated is incredibly important. And a huge meta-study has just been done showing there's a really, really big difference to babies in the first few months of life if the mother has a booster during pregnancy.
Thank you, Sheena. Anthony Costello wanted to say something.
Yeah, I think some of this advice from WHO is being slightly misinterpreted, because as I understand it, they're saying there are high risk, medium risk and low risk groups. And they certainly want all high risk groups to get access to vaccines. The other thing is that WHO have been really worried about two things. First is that routine vaccinations for children have gone down very substantially across the world. And we're seeing, for example, measles outbreaks occurring in many, many countries, rich and poor. So they're trying to, give priority to those diseases that they think are going to have the highest mortality. Certainly with children, they're saying, well, look, children are lower risk for COVID, and therefore it may be a national priority. But that doesn't mean that they're saying that no child should get access to a vaccine. And finally, they're facing this whole problem that we have not got a system in the world to enable vaccines to be distributed fairly. And, companies have made hundreds of billions of dollars out of these mRNA vaccines for COVID, and yet only about, less than a third of people in the poorest countries have had access to it after 2 years of any vaccine. So, that's the problem that they're facing, and we should interpret it more in terms of the national government, but both globally and nationally, high-risk people, like clinically vulnerable people, should be getting the vaccine and access to it.
Okay, thank you very much for that. And this second question covers some of the same territory, but we didn't quite cover it, I think, which is a question from Sue Parry, who says, I'd like to know if there's any evidence yet of immunosuppressed mounting any lasting immunity from the increasing number of vaccines we're being offered. I'm struggling to understand why we're one of the few groups now being offered vaccines. Would it be better to reduce transmission within the non-immunosuppressed? Yes, Alex, please do give us an answer.
I don't have an answer, but I've got part of the puzzle. So, I think what we've seen is a remarkable number of the immune vulnerable have responded to these mRNA vaccines, much more so than we would expect to some of the other recommended vaccines like flu and pneumococcus. So that is some good news. And what we've also found is that in blood cancer cohorts and in our renal cohorts, that patients who have had 3 vaccines have more likely to have a response than 2, 4 than 3, and 5 than 4. So we're almost, the immune vulnerable almost need more of a push to get their immune system to do something. So actually there is some evidence that these repeated vaccines are allowing more people to at least get some protection.
That is really, really useful information, because I think there's a lot of clinicians out there who don't know that. I certainly didn't have that information. Anyone else want to add anything to that? So I suppose really about, yes, Lennard, go on.
I also think we should be investing in the future too, because we need the new generation's vaccines to come through, which last longer, they work for more people, they stop transmission. I've got a feeling if we don't fund this, we don't research it, then we won't have them. things like new therapies like antibodies, new self-replicating products. I mean, they're all there to play for, but if we keep switching off the vaccine programs, then there may not be a demand. That's difficult.
And I guess there's also a question about if we could get better vaccines for people who have competent immune systems, then we might be able to drive down the amount in the circulating in the population, which would protect people who are immunosuppressed. That's really, really interesting. I'm going to move on to the next question, which is from Kirstine Fitzjohn, who says, government's current guidance tells clinically extremely vulnerable people to consider asking visitors to test before they come to our homes. This insultingly assumes that all CEV people only encounter other people at home because they never leave the house. Immunocompromised people would like to live a normal life, going out and about like everyone else. What is the government doing to make it safe for us? Can you persuade them to change the guidance? I think this very much reflects what you were saying, Mark, earlier. Does anyone have any answers? So, Stephen Riker, please.
Yeah, some of you may be aware that last week was the COVID Safety Pledge week of action. It was very successful. Quite a few new organizations, large organizations like universities, like national companies and national organizations signed up to it. And I mean, the logic of the pledge in many ways is to say, for a long time, we've been calling on government. And of course, there are all sorts of things that government could do to make, well, our society in general safer, our public spaces safer. They could, for instance, provide decent sick pay so people don't have to struggle into work when unwell. They could fund and require and inspect decent ventilation in public spaces, but they're not doing it. And I mean, that's tragic, not only in terms of COVID, but more generally, as we've argued over the last 3 years. Clean air is in many ways as important as clean water. The importance of that has been brought home to us with COVID, but it endures beyond COVID. So the argument is, well, we should continue to push government because government should be doing it, but we can also do it for ourselves. And that we can go to businesses, to employers in the public and the private sector and ask them to sign up to the COVID pledge, which is about a commitment to making spaces safer. And in particular, because the lack of safe spaces creates a medical apartheid in this country. One of the tweet threads we had during the week of action was precisely showing the data from the clinically vulnerable families about how many people are reluctant to go into public spaces, including, incidentally, and I'll just finish with this, I found this a quite remarkable statistic. So the survey from the clinically vulnerable families shows that 91%, over 9 in 10 clinically vulnerable people have either cancelled a medical appointment or would cancel a medical appointment for fear about the lack of safety of medical spaces. And one of the things we're making a priority of over the next week or so is safety, decent ventilation, decent practices, decent use of masks in healthcare settings, because I do think it's quite remarkable that we're creating a world, including a medical world, which excludes clinically vulnerable people.
Thank you very much, Steve. I will move on to just one more question. I think we're going to squeeze in one more before we finish. And this question comes from Kerry Gwen, who asks, it's becoming increasingly difficult to carry on with life as the only masker at work, at social events indoors, shopping, etc., to the point where I just don't participate in things anymore, where I used to be able to when there were more people masking. I've never had COVID so far and still don't want to get it, but the pressure to let down my guard is strong. I'd be really interested to know if and where the panel still masks, and if they don't, how do they assess their level of risk? Do antiviral nasal sprays and mouthwashes offer any level of protection if masks aren't worn? So, Trish, you're happy to answer about your own masking.
Yes, well, I mean, I've just come from London to Oxford on the train, and I was certainly masking on the train using a respirator because it was very, very crowded on the train, standing room only. It was very badly ventilated. And as the questioner pointed out, there were only 3 of us on the train who were wearing a mask and everybody else was not wearing one. That is about the most dangerous situation you can get. See if I can share my screen. I don't know if you can see this picture here, which is from a paper that I co-authored with some more mathematically oriented people, but you can see different situations here. At the top, you've got low occupancy and high occupancy. So that's if lots and lots of people are indoors in a poorly ventilated space is the last column. And you can see that your risk of catching COVID goes up dramatically as the spaces are poorly ventilated. And also the more shouting and singing and heavy exercising you're doing. So down in the bottom right-hand corner, even at a prevalence of 0.1%, you've got a 35% chance of catching COVID if you do something like go to a badly ventilated gym. On the other hand, in the top left-hand corner, if you're outdoors and well ventilated, it's really very difficult to catch COVID, even if you're not wearing a mask. So I almost never mask out of doors. The one situation where I might is if I'm going jogging along a pavement, and that's to protect other people rather than to protect me. But the worst places and the places that I would actually avoid are indoor sweaty gyms, indoor places where there's absolutely no ventilation. And I would certainly mask in those. Now I've got the problem that I can't unshare my screen. I shall work out how to do that and hand back to you, Helen.
Thank you very much. While Trish is unsharing, I think
I'm unsharing my screen. Yeah.
I think Steve Griffin was going to tell us a little bit about nasal sprays. Is that right, Steve?
I can. I don't know a huge amount about them. I do know that they are there, and there are different types actually. So there's this sort of type that sort of coats the inside of your nose with a polymer, so almost a plastic. It's not plastic, which prevents infection. It sort of has that extra barrier. There is another type of nasal spray that was trialed and showed some effect, and it's actually nitrous oxide, which is a vasodilator, and that can, if given early, reduce the incidence of severe disease and severe COVID. But I don't believe that these products have ever been trialed in clinically vulnerable people. So I think that the advantage of a mask is always that it's there permanently in a high risk area. You have to remember to apply these things, the preventative ones, ahead of time, and they only last a certain amount of time. So that's the onus is on you to do that. The curative one, I think there's less evidence for, and obviously the ideal is that you don't get infected in the first place. So yeah, I obviously, much like Trish, continue to mask in high risk areas, and both for my own and other people's protection.
Thank you very much. And I think on that note, we're going to have to end this really fascinating session. Thank you, a huge thank you to our guests, Mark Oakley and Alex Richter. I've learned a lot today. I hope you have too. And we will see you all in a fortnight on the next COVID Indie Sage briefing. Bye-bye, everyone.
Bye.
Take care.